Good evening. You are all welcome to the first session of the basic laparoscopic surgery course, where we are going to spend some time discussing a lot of principles involved in laparoscopic surgery training. And of course, this is the first among the series of lectures we are going to have in the course before we will now be involved in practical sessions where we will use our trainer boxes to cover several modules that are provided in the endo trainer, which I will encourage each and every participant to acquire one, because the one we'll be using for training might not be enough. It might not be sufficient for everybody to practice as much as needed. So it is encouraged before we commence the practical session, if possible, you can acquire your own endo trainer. This course, we are going to go in phases. The first phase of the course will involve discussing the principles, the basic principles in laparoscopic surgery. And I believe we all have the outline for the course. Then the second phase, which is the second module, that is the practical session where we will use the endo trainers to simulate a lot of modules that will be provided. There are about 10 modules that come with endo trainers, which improve dexterity and proficiency during your actual laparoscopic training practice, because many publications have shown that most of the laparoscopic surgeons that were involved in a lot of training in the dry lab have better proficiency than those who just go straight ahead on live patients. Next, the third module will be handling of camera by an assistant in laparoscopic surgery, because this is a very important component that is necessary for a successful outcome, because handling a camera, the assistant handling a camera should be as well as good as the surgeon performing the procedures. And the last phase of the training will involve live surgeries on basic laparoscopic procedures like laparoscopic adhesiolysis, diagnostic laparoscopy, appendectomy, cholecystectomy, then hernia repair. Now, these are the basic laparoscopic surgeries that at the end of this course, after maybe assisting a live surgery, 1, 2, or 3 surgeries, after involving actively and participating fully in this course, you should be able to perform this, even though it might take a longer duration. And there are some specialized areas that will also be discussed, like pediatrics, laparoscopic surgery in pediatric patients, urology, as well as gynecology, where some important guests will be invited to deliver lectures on these special areas. So, so by way of introduction, we are going to consider minimal access surgery in general. So now I would like to acknowledge the presence of our HOD. I believe our HOD is...
Good evening, sir.
Good evening, sir. Dr. Oluchi is very resourceful in ensuring that this program come to success. So by way of introduction, now the outline will be following for these introductory lectures on minimal invasive surgery will include the introduction, common characteristics of minimal invasive surgery, the types of minimal invasive surgery, advantages and disadvantages, then determinants of outcome of minimal invasive surgery, then the general principles of laparoscopic surgery, then we'll conclude. Now, minimal invasive surgery is a surgical approach that uses small incisions, specialized instruments, and advanced technology to minimize tissue damage and promote a faster recovery. The goal for minimal invasive surgery is to reduce trauma, that is associated with the traditional open surgery. We all know the metabolic response to trauma following surgery can be minimized by minimal invasive surgery, where you have less tissue destruction, meticulous handling of tissue, and the overall response to trauma will be reduced. There is an overall reduction in anatomical, physiological, and psychological trauma to a patient. It is not only the anatomical and physiological effects that is reduced on a patient. When you perform a surgery on a patient and he wakes up and sees a scar from Cape to Cairo, as we call it, a long midline incision cutting across the entire length of his abdomen, that might have some form of psychological impact on the patient as compared to a patient who will just have a pinhole incisions on the abdomen. Okay, so this is very important. Okay, so these procedures result in smaller scars, less pain, shorter hospital stay, faster recovery times, reduced risk of complications. Now, it is interesting to note that laparoscopic surgeries are done under magnification. The image you are seeing is a magnified image where you see structures clearly outlined. Minimal bleeding might appear as torrential because of the magnification. So that magnification gives you a clearer picture on anatomical dissection and identification of structures. And in turn, this will reduce the risk of complications in patients. Now, the common characteristics of minimal invasive surgery: small incisions that usually range from 0.5 to 2 centimeters, use of laparoscopic and endoscopic instruments, visualization with camera or imaging technology, limited tissue dissection, okay, precise dissection, and suturing. Now, these are characteristics that are common to minimal invasive surgery. So what are the types of minimal invasive surgery? Laparoscopic surgeries, which will be the bulk of our discussion and the aim of this basic course. Endoscopic surgeries, robotic assisted surgeries, arthroscopic surgeries, percutaneous procedures, microsurgeries, natural orifice transluminal endoscopic surgeries. Notes: single incision laparoscopic surgery and mini laparotomy. So are the various types of minimal invasive surgeries. Now, from all what we said, what are the implications of minimal invasive surgery? It is capital intensive. These instruments are very expensive. Disposables that are used are very expensive. Upgrading of a facility is very expensive. It requires updates at intervals. Now, when you are involved in this type of surgery, you will see advancement regularly in all the devices you are using. There is continuous modification of the devices and even all the hand instruments that are used in this area. Now, theater times are increased initially. Don't be discouraged. When you commence laparoscopic surgery and you start spending 3 hours, 4 hours, 5 hours, initially, don't be discouraged. With time, the time decreases as the surgeon gains experience. Now, more so with updates of the instrument that are being used, surgeons tend to become faster. Now, especially the energy devices that we use. Now, some of these energy devices are advanced and they enhance surgery, the speed of surgery, and better outcome. If you compare a surgeon just using a diatemy, maybe an L hook, and a surgeon that is using a ligature or harmonic scalpel, of course, these harmonic scalpels are more advanced tools for dissection. So you expect faster and better outcome. Short stay reduces accommodation cost, free up main ward bed space, and reduce waiting time. This is very important, especially for administrators. The overall implication of laparoscopic surgery is, even though it is capital intensive, but they tend to benefit more in laparoscopic or minimal invasive surgery. And the beauty is most surgeries can be done with minimal invasive surgeries now. Even in the past, several surgeries that were contraindicated are now considered as an indication for the procedure. Now, minimal access surgery is largely founded on a team-based approach. You see, this procedure is not a one-man show. You cannot be a surgeon, be a peri-operative nurse, be a biomedical engineer at the same time and be the assistant. It's not possible. It's practically impossible. So you must go along with your team. The peri-operative nurses are very important. The biomedical engineers are very important, as well as your assistants. So each and every member of the team must understand what is going on. It means the basic principles, the knowledge in the basic principles of laparoscopic surgery is the foundation before you go into this procedure. Because it's a teamwork, it's not a one-man show. Complicated procedures are performed with complex equipment that requires constant maintenance and upkeep. During surgery, multiple intraoperative adjustments of equipment, the camera and monitor, are required, which demand skilled and collaborative team that work in a coordinated fashion to ensure patient safety and successful outcome. Not that you want to do laparoscopic surgery, you are looking for the telescope, it's nowhere to be found. The cable is missing, no suction tube. Your assistant is not around. The entire process becomes frustrating. Now, it must be a teamwork that is done in a collaborative manner. Now, examples of minimal invasive surgeries or minimal access surgeries. As we mentioned, at the end of this course, it is expected that we should be able to perform the basic laparoscopic surgeries, which after our simulation, handling of the cameras, partaking in live surgeries and assisting surgeries, you should be able to do basic ones like diagnostic laparoscopy, cholecystectomy, appendectomy, hernia repair, adhesiolysis, arthroscopy. There are more advanced laparoscopic surgeries which requires advanced training by experienced proctors. You will see a trainer who has 20 years of laparoscopic experience, 30 years of laparoscopic experience in a designed formal training where laparoscopic surgeons with basic laparoscopic training go for an advanced training. And of course, these trainings are not, they cannot be too much. As the more you go, the more exposure you have and the more experience you acquire from people that are highly skillful and that are highly exposed to these procedures. You can see all the advanced procedures like Nissen fundoplication, repair of perforated duodenal ulcers, halar serocardiomaectomy, gastrectomies, hepatectomies, adrenalectomies, splenectomies, nephrectomy, uverectomy, hysterectomy, prostatectomy. So these are advanced procedures. Now, the advantages and disadvantages of minimal access surgery. As we mentioned earlier, smaller incisions with less post-operative pain and disability, improved cosmesis, because these are tiny pinholes, incisions, they have tiny scars with better cosmesis as compared to open surgery. Decreased wound-related pathology such as wound infection and hernia. Decreased tissue trauma. Decreased physiological insult, because the metabolic response to trauma is reduced. They significantly reduce hospital stay, improving cost effectiveness, improved visualization of the operative field for the whole surgical team, including trainees and students. And this is enhanced because of the magnification and as well as advances that leads to recording and projection of these procedures we do. There are devices that are meant to record all these procedures, and they can be projected for trainees to follow. Now, there's decreased contact with pathogens such as human immunodeficiency virus, HIV, hepatitis B virus for the surgical team. Now, use of video records aids communication with patients and their families. Now, most of our patients that come for minimal invasive surgery, you'll see them providing their phones for the procedures to be recorded so that they will have a detail of the intra-operative findings. But of course, if you have devices that are designated for all these recordings, they can even be edited and only the relevant parts of the procedures are provided for the patient. Now, the disadvantages of minimal access surgery will include loss of tactile feedback from tissue and instrument, because as you handle the tissue with instruments, not your fingers. So there is loss of tactile feedback. There's potential difficulty in controlling major bleeding, which may be associated with a rapid deterioration in visual field. If the bleeding is so much, you might not be able to see the field, and eventually you may have to convert to open procedure. Now, your thresholds shouldn't be too, don't worry at the initial phase if the threshold of conversion is high for you, because it's safer. Safety first. Don't be disappointed because you injure a vessel and you convert. Because if you insist that you want to continue, you might not be able to secure hemostasis, and at the end, you end up with a serious complication that might be debilitating or even compromising the life of the patient. So, longer procedure times, especially on initial slope of surgical learning curve. So, initially, when I was reviewing the charts of the few laparoscopic surgeries I did, I saw the initial surgeries were extremely long, but with time, the timing kept on reducing gradually. So initially, don't be disappointed, and you will see with time in fact, when I sent the chart to one of my trainer, the response she made was terrible. When she saw the timing, she just replied terrible, and she sent a gesture of laughter. And the other trainer now said, don't be discouraged, just keep on the good work. And of course, the timing started reducing gradually. Okay, the requirement for specialist instrumentation and an appropriate surgical skill set. You have to get specialized instrument, greater potential for iatrogenic damage, either through surgical deterioration, e.g. bile duct injury, or unrecognized visceral injury, missed bowel perforation. And this is a common disadvantage. And of course, you know, the knowledge of anatomy and laparoscopic anatomy is very essential in these surgeries. So what are the determinants of outcome in minimal access surgery? The determinants are categorized into patient-related, surgeon-related, technique-related, and others. The surgeon-related factors will include experience and training in minimal access surgery. Now, it is very important you go through the basic laparoscopic surgery training, which we just commenced, starting with the principles and foundation, which is the foundation of the training, then training using endo trainers or simulators before going into live patients. Because these surgeons tend to be better than those who just delve into this business without getting a good grasp of the foundation of minimal invasive surgery, because you tend to have a longer learning curve than somebody who passed through a basic training, because basic training will give you an idea of what is going on. You understand the entire process, and your learning process will be faster, because as an experienced surgeon is operating, you understand what he's doing, even if he's not teaching. But because you already have a good foundation, so your learning process will be faster. And of course, I can testify to this. When I went for training with ICAD, they just say, go ahead, do a cholecystectomy, do an appendectomy. Nobody will start teaching you how to tie knots, not tying. So if you have not you are not involved in all the basic training, suturing, laparoscopic suturing, all those knot tying, and you go for a more advanced training where the proctors might not have time, because all those trainings are short. Nobody will have time to start using an endo trainer to teach you. So this is something that you must be involving before going for any trainer that will involve live patients. Okay. So the skill level and proficiency also determines the outcome. Then familiarity with the instrument and technology. Now, among the series of lectures we will discuss will be instrumentation. It is very important all the members of the team understand, will be able to identify all the instruments and understand their functions, because during the procedure, especially the peri-op nurses, they should be able to identify what a surgeon needs and when he needs it. Okay, so it's very important we all become very familiar to this, all the instruments. Now, decision making and judgment, because during the procedure you might be in a dilemma where your decision will determine the outcome. You might want to proceed, you might want to convert in case of maybe difficulty like injury, bleeding, and bizarre and distorted anatomy where you cannot proceed. So you have to make a decision, and this is highly influenced by your level of exposure and your background knowledge of the subject matter. So communication with the patient and team members. Now, it is very important you understand during this procedure. As I said, these processes, they are not one-man show, it's a teamwork. So patient-related factor like age and overall health status of the patient. You know, debilitated patients will have poor outcome as compared to a patient with a better performance status. Patients with comorbidities have poorer outcome than those without comorbidities. Then obesity. In obesity, there are distortion of anatomical planes. You might insert a pot you think is in the right iliac fossa, but of course, it's just a flap of fat that is just dangling down, and you are passing the instrument. You just realize that you are just somewhere either in the groin or somewhere in the hypochondrial region. So even the instruments that are used for obese patients are longer. Okay, so this actually determines the outcome. Then nutritional status of patients. If all these factors are common for both open and laparoscopic surgery, not only in minimal access surgery. Then previous surgeries and abdominal scar. When there are previous surgeries, of course, there will be a lot of scars, and this will limit your access points. The adhesions between the viscera and the scar might cause injury when you are trying to enter the abdomen, because the viscous will adhere to the site of previous injury, previous scar. And of course, when insufflation might even be difficult for you. Now, there are technique-related factors like the choice of your approach, the instrument and equipment quality. Now you are operating, you are not using a HD camera, HD instrument. You are even having a doubt, is it the cystic artery or the cystic duct? You are not sure because you have a very poor picture. Okay, so if you have a poor instrument, archaic old instruments and things that are not clear, okay, as if you are watching one old in black and white screen. So you might have higher tendencies to injury compared to someone who is just seeing the structures as if they are in front of him and they are highly magnified because he's using a more advanced equipment with higher resolution, which of course this will have a lot of cost implication. Now, port placement and access strategy. Now, you will come to know in due course that placement of ports will determine your surgery. One important aspect that every laparoscopic surgeon should know is mastering the site of port placement for every laparoscopic procedures and alternative approaches in case there are challenges for the conventional approach of pot placement. You will come to see that during pot placement, if your pots are not placed correctly, you might have swording. Your instrument will just be swording with each other in the abdominal cavity. Okay, so there are designated points where these instruments should be introduced. Dissection and suturing technique. Now, the basic laparoscopic training, this course will help each and every one of us to master how to suture correctly. And why I encourage each and every member to acquire his or her endo trainer is you can do this practice at the comfort of your room. You don't have to come to the class, and the limited time you have, you'll be practicing, because we have only 2 boxes now. So if you acquire your own at the comfort of your room, it will just be like a video game for you. So you keep on practicing, and the more you practice, you'll be surprised how fast you can become very good and proficient with all this procedure. Then hemostasis and bleeding control. So if you have facility or instrument that can give a better hemostasis or bleeding control, the outcome are better than you struggling with an archaic instrument that is provoking more bleeding. Then visualization and exposure, then conversion to open if necessary. Don't refuse conversion, because even the best of hands in this procedure, the best surgeons, the best laparoscopic surgeons do convert to open if they come across difficult challenges. So other factors which determines the outcome will be hospital and facility resources. There are some hospitals where the facilities are very poor. You'll be operating with a lot of difficulty. And if you are not patient, you will just be frustrated. And the entire process will just die down. But if you are patient and keep on pushing, your hospital might upgrade the facility they have. And of course, the better for all the surgeons who utilize this technique. Then the anesthesia and perioperative care. Laparoscopic anesthesia is different because there are some special considerations during laparoscopic surgery, which we will discuss in due course. Then patient selection and indication for minimal access surgery. Now, you have to carefully select patients. It's just not because you want to be a laparoscopic surgeon or you think you are a super surgeon, you just start booking all your procedures under laparoscopic surgery and causing havoc to patients. You just start causing unnecessary complication. Don't forget, patient selection is still applicable here, just as in open surgeries, because of course, you know, if you don't carefully select patients and those that are indicated, you can't just go and start doing. For example, you are just a new beginner and you have a patient with gastric perforation. You say, no, let me just go and do laparoscopic surgery. And you know the implication of generalized peritonitis. You then go to the theater with laparoscopic anesthesia, with your poor technique. You go and spend 18 hours, and at the end, you now convert the patient to open, doing basic surgical skills on your patient. That is not acceptable. If you want a basic surgical skills, you have to get an endo trainer. So you have to select patient carefully. Even perforated appendix with generalized peritonitis, it's only those who are experts, those who are grounded as a beginner. Don't select those kind of patients. Just go straightforward, simple, uncomplicated appendicitis. Okay, straightforward cholecystectomy. In fact, if there is pus there, if there is empyema, don't even go for laparoscopic if you are a beginner. And all those. So patient selection is very important. Intraoperative complication and how they are managed also determine the outcome. Then post-operative care, okay? Post-operative care in the patients and follow-up. Now, the general principles in laparoscopic surgery. Now, all what we've been saying is generally on minimal invasive surgeries, which of course we classify them, we give the various types and examples. Now, to be more precise, the laparoscopic surgery is a type of minimal invasive surgical technique that utilizes laparoscope, as you can see the laparoscope here, these telescopes, and instruments inserted through small incision to perform procedures. Now, we will see the details of all these during instrumentation. It has revolutionized the field of surgery, enabling complex techniques to be performed through this approach with better outcomes. Now, the general principles in laparoscopic surgery include, now these are the general principles when you are preparing a patient for a laparoscopic surgery. You have to follow these principles. When you say principles, they are those measures you take in the preoperative, intraoperative, and postoperative period to achieve a better and successful outcome. That is principles in surgery. So the general principles in laparoscopic surgery include adequate preoperative preparation. You take detailed history of the patient, a complete physical examination, investigate the patient thoroughly. Not that it is when you go to the theater you discover that the patient has bleeding tendencies. Okay, correction of all physiologic derangement. Okay, you have to optimize your patient and you admit a patient prior to surgery. Okay, now you have to obtain consent, informed consent. When you say informed consent, okay, the patient has to know of the diagnosis, okay, the procedures and the related complications of that procedure. And you have to obtain permission to convert to laparoscopic surgery. Not, as we said, they are expensive surgeries. Patients, you don't take consent. He just wakes up expecting 3 button hole incisions or scars. He just recovers and see a scar from xiphistanoid to the pubic symphysis. That is when you now start explanation. So, and if the patient, if you don't counsel for that, you see, you'll be in trouble. So you have to obtain informed consent and permission. So all laparoscopic procedures, there must be consent for and permission to convert to open surgeries. Then prophylaxis. The prophylaxis that are considered are DVT prophylaxis, antibiotic prophylaxis, and boil preparation, especially for colonic surgeries. Now, there should be adequate analgesia, equipment. Every member of the team should be familiar with the instrument, because if the peri-op is not familiar with the instrument, the surgeon is going to suffer. And the procedure is going to take an extremely longer time. So I think when you are doing a laparoscopic surgery, you need an experienced perioperative nurse. In fact, sometimes they even give you suggestion that you should do this, do that, because when you have an experienced perioperative nurse, they have operated with so many experienced surgeons. Okay, so your access must be safe and effective. You have to master the proper point of entry. You cannot just go and start inserting ports anyhow. Okay, there is a principle that guides your port placement, which you must be very conversant with. Then visualization, you should have a high quality visualization of the field with laparoscope and camera. Then there should be good illumination, adequate lighting of the field. The light source is connected to the telescope. When we see classification, in our next lecture, we'll discuss the classification of laparoscopic instruments, and this will make more sense and you understand better. So the exposure, there should be adequate insufflation. Now, if your ports are faulty and they kept on leaking, you are going to suffer in that procedure. If you have ports that are leaking and you proceed with the surgery, you'll be wasting CO2, you'll be suffering, the abdomen will be collapsing, you will not be sane, and the entire procedure will be unnecessarily too lengthy. Then exposure of operating sites using graspers. So adequate exposure. If you are operating, to get access to the organ you want to operate on, you need graspers to clear the field, all the bowel or other structures that are covering the structure you are heading to. Then your dissection should be with precision and gentle dissection of tissue. Hemostasis, there should be effective control of bleeding, and suturing and knot tying. You should have ability to perform suturing and knot tying, and this is actually dependent on your extent of involvement in the practice. Now, tissue handling should be gentle with precision to avoid trauma. Now, special awareness. You see, you must have, you should be able to correlate the spatial awareness of what you are seeing on the monitor on the patient you are operating. You might have some difficulty in understanding the orientation when comparing what is on the camera and how the ergonomics of your hands are moving. So this is what is achieved with time and training. When you frequent the procedure, you tend to understand the ergonomics better. Okay, the laparoscopic anatomy and spatial relationship. Teamwork, you should communicate effectively with other members of the team and collaborate. No any member should frustrate a laparoscopic procedure. Your entire goal should center around the patient and how to achieve a better outcome. Okay, so next, patient positioning. Okay, patients must be positioned properly depending on the type of procedure you are performing. Then effective energy source. You should have a very effective energy source, like your diatemy, your ligatures, your harmonic scalpel, and so on. Then specimen retrieval should be safe and very effective, especially if you are dealing with infected specimen or specimen with suspected malignancy, they should be collected in retrieval bags so that they don't seed the tract when you are removing through the pot site incision. If they are infected specimen, you have tendency of having a pot site infection. If they are specimen with suspected malignancy or malignant specimen, you might seed the tract, the pot site. Now, closure of trocar sites and the incision. So those are the basic principles of laparoscopic surgery. So in conclusion, a successful laparoscopic surgery requires knowledge, proper training, and adhering to the surgical principles. A surgeon must be able to identify patients who needs the procedure and when conversion is necessary. Mastery results from sound knowledge of principle, dedication, regular practice, confidence, training, and precision. So we have come to the end of the first lecture, which is the introductory lecture, and the first lecture in module 1 of the procedure. So we are going to stop here. Then it's time to entertain comments, questions, and contributions. Thank you very much.